and then you put the paint on the board, and it's still wet, you could technically wipe the paint off the board. So if your reaction is going boards plus paint is painted boards, you could technically wipe it off and go back to having painted boards. You did a good job scraping the paint off, correct?
I didn't mean to take three. I took pictures, and I accidentally took like 4 pictures of you.
Oh, okay. Alright. So, but then if you leave the paint on the board, the paint dries, and what you end up with is painted boards. Correct? Which is your product. So if you consider your boards as your enzyme, your paint as your substrate, what you're going to end up with is an enzyme substrate complex. And again, at this point, it's still reversible. Okay? And then if you let it dry, you end up with a product, which is painted boards. Okay? All right. So, who's going to paint the boards? Does the paint just magically appear on the board somewhere? No. The painter paints the boards. So you're the painter, right? Right? So if you were the painter, at the end of the whole process, are you still you? So you're the catalyst, right? You make the product happen. Okay? All right. Okay. So, how would this process go faster? If I put 200 boards in front of you, would that make you go faster? Not necessarily, right? What would stop the process?
Lack of boards.
Lack of boards, or you run out of paint, right? Okay. But what if all of us were painting the boards? Would that make the process faster?
Yeah.
Okay. So you have your enzyme that causes the reaction to happen, and then you have coenzymes, which are the people that are helping you. Okay, does that make sense? I don't know if it helped you or not. Did it help you? How do you go through the process of what's really happening?
Like just put IgM, IgA.
Yes, yes,
Okay.
yeah. At first I thought it was I don't know.
Well, that's easy.
And it is, but I didn't want you to study it one way and go, well, Barb told us.
And they're all just with IG in front of them, right?
Right. Nothing hard. And again, that's all you need to know from me because you're going to get slammed with it in serology. And then the other thing I told you was 2 functions of the liver. You actually need to know 4. Yes, ma'am.
So you use enzymes, of course, S, what is S?
Substrate.
Substrate, you use enzyme substrate,
Right, you're right.
and then P is protein.
Right. It's in your PowerPoint. I was just trying to give you a little picture in your head to maybe help you as we go along. You can totally forget it if it didn't help you at all. So if you have that worksheet that's due, you can have it right along with your notes. And then we're going to probably answer most of the questions on that worksheet.
Which sheet was that?
Enzyme worksheet. I'll give you technical questions if you don't have. It should be in your syllabus though, I think. Which is this address?
It's page 11 of the syllabus.
Enzyme.
Are you gonna have a C up there?
Again, an enzyme is a biological protein that catalyzes a chemical reaction. The enzyme causes the reaction to happen. Again, you have boards, you have paint. How is the paint going to get on the board? You have to have the enzyme that does it. In the process of painting the boards, again, the enzyme doesn't get used up. Okay, it doesn't undergo any changes. So technically, could you keep using? You can be painting boards all day, right? Okay. So that's just a definition of a catalyst, again, something that's going to cause a reaction to happen. It doesn't get used up in the process. So enzymes, much like proteins, can have a single structure, primary structure, just a chain of proteins inside. Secondary structure, okay, basically kind of side by side. Tertiary, kind of chains and folds. And then quaternary, you kind of get, I was thinking about doing this last night, I was like, I don't know. Anyway, so twists and folds. And then when you do it, sometimes you get a hook. And sometimes that hook is actually the part that the enzyme will work on. So, primary, second, again, just like with enzymes. Or I'm sorry, proteins. So the active site is the place on the enzyme, and again, it might be the cavity, it might be a hole where the substrate can, which the enzyme acts. Okay. You can have an isoenzyme. So again, that's your twin brother. Okay, are you exactly the same? No, but both twins can paint boards, right? You have your isoenzyme. Okay. So if you have a main class of enzyme, if your main class is people, isoenzymes are boys and girls. Easy enough, right? Cofactor is a non-protein molecule which may be necessary for the enzyme activity. So you can almost think of your cofactor as your nagging wife telling you that she wants the fence painted, and it's going to make you go do your job because you're not doing it. It's just sitting there. So my husband today to chop down the weeds that look like trees now, he just looked at me like, yeah, right. So we'll see if that gets done when I get home. Cofactors, non-protein entities again, so it can be metallic, non-metallic. It's just some cofactors. A coenzyme is an organic cofactor. So when you add all that up, cofactor plus your enzyme equals a prosthetic group. The enzyme in the prosthetic group is called the apoenzyme. The apoenzyme plus the coenzyme, its name is called the holoenzyme. Kind of basically how it comes together.
Jeez.
I'm being annoying, I'm sorry.
That's all right. What are you trying to do?
Kind of punch whole thing. I got a little bitty one too.
Oh.
It makes too much noise.
Bad time for that, sorry.
How many pages does it do for like at a time?
Like
It's
2,
two
3,
versions.
it's not that many.
So it's just enough to put in your notebook.
Yeah.
Yeah, a whole bunch of them. Okay. So how the enzymes got their name, okay, is by the activity in which they are causing to happen, okay? So in some cases, it would be the forward reaction that would give it its name. And in some cases, it would be the reverse reaction that would give it its name, okay? All enzymes end in ASE. Now we know what they are. So if they're an oxidoreductase, what do you think an oxidoreductase does? Oxidation reduction reaction, exactly right. So examples of that are LDH and G6PD. LDH, we'll talk in great detail. G6PD, have you talked about that one at all? That's the one that you might have learned in hematology, right? Okay. Then you have your transferases, and they just transfer a group from one, other than hydrogen, to one group to another. AST and ALT, we talked about those yesterday. What is AST and ALT? Liver, yes. CK and then GGT, B. No, GGT is one that is a good alcohol marker. We kind of talked about that with that group that was stayed over with the CH40. And then you got hydrolases that hydrolase various bonds, so your alkphos, your acid phos, your amylase. And we'll talk about each one of those enzymes separately. Those are just kind of some classes that they have. Okay, so here's your enzyme kinetics, right? Your enzyme plus your substrate gives you that enzyme substrate complex, which is, that point is reversible. So if the paint is still wet on the boards, you can take the paint off, okay? And then again, you end up with your enzyme plus your product. Sorry, I got my little enzyme again. The enzyme is, again, that's you. You didn't get used up in the process. You might have some paint on your shirt or paint on your clothes, but you're still much tired. Get your ex-wife off your back. So activation energy is basically the amount of, energy required to raise one molecule in 1 mole of compound to a certain temperature. So enzymes work by lowering the activation energy. The reactions and just definitions. On your test, you are going to be able to regurgitate this statement for me. And again, at this point, it's reversible. And at this point, your paint, your boards are dry, and you have a product, and you have to okay, so we said that, so these are some factors that will affect the actual rate of the reaction. We kind of hit on this just a hair. So substrate. If I run out of paint, if paint is my substrate, can I paint any more boards? No, your reaction is going to stop, correct? Okay. And again, if I run out of enzyme, is my reaction going to keep happening? So if the UR used up in the process, is my reaction going to keep happening? No, all right. So again, some things that affect the reaction. pH is very, enzymes are very sensitive to pH. And so that's why a lot of the reagents have to be in a certain pH range to get what enzyme that they're looking for to actually do the reaction. Okay, so again, it's controlled by the reagent. Temperature, this is where your machine comes in play. Our machine was cold yesterday. Did it like it? No, it did not like it. So what did we have to do? I just kind of kept talking and talking and talking until our temperature finally came into range, right? Okay. Just like with proteins, we can denature our enzyme, right? And it will not, so it will not work if the temperature is too high. We don't tend to have, in the lab, we don't tend to have it too cold. We really don't, because we usually have so many machines running, we tend to have a problem keeping the temperature down. So, on numerous occasions, we've had a machine that's telling us it's over temp hot, okay? Our enzymes are going to be the first ones affected because they're a little more sensitive than proteins, and proteins probably after that. So if I have a machine that stops running because it's over temp high, what do I need to do as a tech? What's the first thing I'm going to do? It's probably already shut itself down.
Take the reagents out. Oh, put in a report.
No, what's the first thing I'm going to do to cool it off?
A fan.
Yes. Okay? You're going to open up the doors and you're going to try to cool it off with a fan. Okay, that's the first thing you're going to do. All right? If the fan works enough to bring your temperature down to where the machine says, okay, I can run, now what do you have to do?
Take the reagents out.
Right. Are my reagents any good? Maybe, maybe not. So I need to run a set of controls. Why not? If I can run a set of controls and my controls work, do I have to take off my reagents? No, I'm okay. But if my controls do not work, you're going to have to replace your reagents because your reagent got too high.
But wouldn't you want to take them off first to try and save them? Like get them into a fridge or wherever they
Well, and if you only had one or two, that would be great. But you got to consider you've probably got 36. So yes, long term, you would want to take them off the machine. But if you're working on the machine right now, okay, and it says it's hot, it gives you a warning, it says it's hot. You're going to walk over to that machine, you're going to open the doors, you're going to put a fan in front of it, and you're going to try to cool it down. And then while that's happening, you're going to probably call your physical plant or whatever and say, hey, what can you do about the temperature in here? It's really, really hot. Okay. We've been known to have little external air conditioners that we can actually pull over to a machine. So again, it's going to be dependent on what your lab is, but I'm just kind of giving you some ideas on what you can do. So to pull them all off, no, that's probably not your first step because you have so many that you would want to try to do a fan or try to do something where you can cool it off. But because you did not remove them, you have to make sure they're okay before you start rerunning functions. After you get a warning like that. Make sense? Yep. And then you would, then if that didn't work, then you would have to replace it. So it is very, very sensitive to temperature. Let's obviously cofactors, we talked a little bit about cofactors already, and the fact that they will increase the rate of reaction. So again, if a cofactor is just another person, your rate of reaction is going to go faster because you have two people doing it, right? You can have inhibitors that will interfere with the rate of reaction. So that's that little 3-year-old that says, come on, I want to go play. I don't want to paint boards, right? I want to go play. So they can be a competitive inhibitor, and that is reversible. If you get rid of the competitive inhibitor, make a little kid go in and play with mom, it is reversible. Your reaction will go. You can have non-competitive inhibitors, which can be either reversible or non-reversible. And then you have uncompetitive inhibitors. And in that case, that's that little kid that just will not, that's the dog, I guess, that will not let you stop playing fetch. And so you end up with no product at the end, no period force. Okay? Again, just some definitions. So enzyme measurement activity, what is measured? We can measure an increase in product concentration. So we can, so the end product, if there's an increase in the amount of painted boards that we have, that can be what we measure, okay? We can measure how much paint we used up, right? That can give us an idea of how much product and enzyme we had, correct? Okay? A decrease in coenzyme concentration or an increase in altered coenzyme concentration. Some things that we can measure in the activity that we're doing to find out what is actually going on, okay? You can have a fixed, so in the lab we can have a fixed time assay. So basically it's kind of like what you're doing right now with the manual procedures. Did you not on the total protein yesterday, you took your reagent, you added your patient specimen, you put it in the spec and you got an answer. After it said to incubate for what, 1 minute, 5 minutes or something like that, room temp, I think incubation.
Mm-hmm.
I don't remember.
It's 5 minutes.
Was it 5 minutes at room temp? Okay. So a fixed time. You add it, you wait for your fixed time, take one measure. Fixed time. Then there's something called a continuous monitoring or a kinetic assay. In that case, and I tried this one time with our specs, and it was kind of interesting, but it really didn't work. And so once it expired, I couldn't tell Gene if I needed more. So with this one, you added your reagent, you added your patient sample, you put it in the spec. And then at 30 seconds, you read your absorbance. At a minute, you read your absorbance. At a minute and a half, you read your absorbance because your needle kept moving because the reaction was happening over time. And you took multiple readings, and then you did a calculation and you found out the activity. Okay? So fixed time, add it, wait your time, one reading. Continuous monitoring, you're watching it over time. It's something that you can do. Depending on what measurement we're doing. Yeah, I can have a 0 order. And a 0 order is dependent on the enzyme concentration only. Okay? So the enzyme concentrations are always, and so in the lab, when we're looking for enzymes, we always do 0 order. Okay, we always do 0 order. First order, that's your Michaelis-Menten constant, and that is proportional to the substrate concentration. So technically, you could keep adding more substrate to the product, right, or to the process, and you can keep feeding more boards. But that's not what we're looking for. We're looking for enzymes, and so we're going by what the enzyme concentration is versus first order. Okay, your unit for enzyme, so like protein was milligrams per deciliter, or grams per deciliter? Grams per deciliter. Glucose is milligrams per deciliter, okay? For enzymes, it is an international unit, and that is the amount of enzymes that will catalyze the reaction of 1 micromole of substance per minute under controlled circumstances. So that's the definition of the unit in the international unit. We can use enzymes as reagents. So somebody tell me an enzyme we've already talked about that's going to be used as a reagent. I'm sorry? Lipase, exactly right. So we can use an enzyme as a reagent. So, so again, hexokinase, which is your reference method for glucose, right? And then cholesterol. Do we remember what the one for cholesterol was? We didn't really stress that one. And then uric acid is uricase, all right? which we'll get into in that uric acid lecture. Okay. So again, you can use enzymes as reagents as well. So again, what do we worry about in the laboratory? If our enzyme is a reagent, carry over to the patient. Exactly. You got it. Okay, so why are we measuring enzymes? The clinical significance in chemistry. If you have tissue damage, you know your body has to function, right? And so enzymes cause reactions in your body so your body functions. So we know you have enzymes. When you have tissue damage, the enzymes will leach out of the tissue into the blood. So then we draw your blood and we test for the enzyme. We can tell what organ is damaged. Again, AST, ALT, liver. You damage your liver because you're taking some kind of drug. If we test for that liver enzyme, we will know that you're hurting your liver. Make sense? Okay. So it can be a direct attack, reduced blood flow, trauma, altered production. Can be some reason. So that's why we're doing it. Finding out if we have tissue damage. Yes?
AST isn't only in the liver though, it's produced in the smooth muscle, red blood cells, and mitochondria as well. So if it was ALT, you know it was the liver for sure, but if it was AST, there could still be.
We get there.
Okay.
Okay. All right. So here's your worksheet. Talk about each of the enzymes. You have an enzyme called acid phosphatase. Acid phosphatase is very high in the prostate. Yes. Okay. So it's very high in the prostate. So, and you have a high level in semen. So why would an acid phosphatase do well in a rape case?
Because you can give the semen.
You would find out of whether or not there was any semen in the specimen. Exactly right. So if I had a female, would she have a high level of acid phosphatase normally?
No.
No. Right? So again, it would be a good idea. Acid phosphatase was used in cases like that to determine whether there was a rape case or something like that for as a source of semen. If it's high in the prostate, would it be elevated in prostatic cancer? Why not?
Because your prostate's not working correctly.
But the cancer is taking over the tissue. What does the cancer cells do? Do they make your prostate work correctly?
No.
They damage the tissue, right?
Yeah. So it can't
So it would
produce
be
the acid phosphatase.
so it would be increased, correct? And this was one that we used when we were looking for prostate cancer. However, the PSA that you've already learned is a tumor marker is a much better marker for prostate cancer. So this has kind of gone away as far as prostate marker. Okay. Source of error, it is increased with hemolysis, decreased at room temperature. So if I have a hemolyzed specimen, my acid phosphatase is going to be falsely elevated. If I leave my specimen on the counter for 3 days, what's going to happen to my value? Right, so that's why we store our specimen. Not the only reason, but one of the reasons why we store it in the refrigerator. Okay. Oh, let me go back. Okay, so it is an acid pH. And what is a value for an acid pH?
Or less than 7.
Right. And it's 5. I don't know why that's not on here, but it should be 5. 5 to 6 is a good acid phosphatase. Alkaline phosphatase. Again, phosphatase is your enzyme, right? And now it's alkaline. So you use a pH of 9 to 10, so it's higher, your alkaline range. Your sources for your alkaline phosphatase, liver and bone. And what are osteoclasts versus osteoclasts?
Breaks it up.
Right. Osteoclast builds it, and osteoclast builds it, osteoclast takes it down. So this is building your bone, all right? Elevated and obstructive liver conditions. Talked about that a little bit yesterday. Elevated in bone disorders such as Paget's disease, rickets, healing, growth, or pregnancy. So those really aren't disorders. But why would your alkaline phosphatase be increased in healing, growth, or pregnancy?
Because you're creating bones, so you're
Because it's
creating.
the osteoblast, you're creating bones. Exactly right, exactly right. So are your normal values higher for children than they are for adults? Yes, they are. Yes, they are. Okay. Source of error, hemolysis increases the value. So if you want at the end, I don't know if you just want to put an arrow up or an arrow down, however it's good for you as far as with the hemolysis at the very end. Okay. And again, storage at room temp or using an old specimen can cause a problem. Your transaminases, AST and ALT, they are transfers. They transfer. Your source, AST, myocardial, liver, smooth muscle, and red blood cells. ALT, liver. So if I run an AST and an ALT at the exact same time, and my AST is elevated but my ALT is normal, what could that tell me? Your AST is normal, elevated, but your ALT is normal.
Liver's fine.
It's something else, not your liver.
I'm sorry?
It's not your liver then.
Right. So the main two that we really think about with AST is heart and liver. And I know it's in those other ones, but heart and liver. So if my ALT is normal, my AST is elevated, yeah, my ALT is normal, then I know it's heart. Okay. So elevated ALT and AST, think of your liver. Normal ALT and increased AST, it's your heart. And again, source of error for your AST, increased value, significantly increased value.
So hemolysis doesn't affect.
Doesn't affect your ALT, but it does increase your AST. Amylase, abbreviated AMY, but I can honestly say, so AST, ALT, we usually say the abbreviation. Alk-phos, we usually say the abbreviation. Lipase and amylase, we usually say the entire word, but AMY is your abbreviation, okay? The main source for your amylase is pancreas. That's your main source. However, it is also in your salivary glands. It does help break down your food. Has anybody known anyone that's had a salivary stone? A stone in their salivary gland? And their face puffed up every time she
Yeah.
smells food?
And how they fix it is give you hard candy to suck on. It tries to draw out the stone.
Really?
Yeah.
Wow. Because I had a student who said they actually had one, and it said the doctor actually went in with like a needle.
Oh,
And
really?
actually, yeah, made them smell like coffee or something that would cause them to salivate, and it got, so I mean, they said their face just puffed up really big. The doctor went in there with a needle and just kind of did something, and the stone popped out, and all of a sudden, they said it just spit all over the doctor. Yeah, so, yeah. Source of error, again, inhibited by triglycerides, can be increased by drugs.
So if it doesn't say that it is
Then it's not
hemolysis,
affected by hemolysis.
so then it's just not affected.
So amylase, think of acute pancreatitis. That's what I want you to really think about with amylase. Acute pancreatitis. Okay. The other things, yes, but that's the one I want you to remember. Lipase is Amy's friend. They increase together, they decrease together, they like to run hand in hand, all right? So again, your source is your pancreas. They're going to be elevated in acute pancreatitis and also in duct blockage, but acute pancreatitis, okay? Inhibited by hemolysis, which means you would get a false low result. And again, it interferes with triglyceride measurement in some instruments, and we've already touched on that in our triglyceride lecture. So amylase and lipase together. Pancreatitis, think about them both. You need to borrow my little fan, don't you? Cholinesterase. Cholinesterase is one that we can use for insecticide poisoning. So if you have that person who works for Terminex or whatever, and they're getting the stuff off their truck, and they get themselves doused with whatever insecticide they're using for, we could do a cholinesterase to find out whether or not they're having any problem with an insecticide poisoning. Or, let's see. Pseudocholinesterase is probably the one we measure in the laboratory more than the acetyl. But again, we can do it. So more the source of error, again, increased with hemolysis.
You said increased hemolysis?
And I was actually watching an episode of, I don't know, some doctor show, and the person was a little boy who'd gotten into his dad's garage and came into the ER in bad shape. He had powder all over him, and come to find out that he had gotten into some kind of pesticide that the father was using, and he actually said, "Let's order a cholinesterase." I thought, yes, that's the right one to order. Okay, creatinine kinase. Creatinine kinase, CK, is one that we're going to have more information on in your cardiac marker lecture. Okay, so it actually is in both. We do use it as a cardiac marker. There are 3 isoenzymes. Remember I told you in the very beginning your isoenzymes are like you and your twins, right? Okay, so there are 3, so they're triplets. So if you took your CK and you had 3, so you have 3 isoenzymes, CKBB comes from brain tissue. CKMB is your heart. CKMM we think more of as muscle. I know that's so here, just draw, and I'm sure they are, but just draw a single line through that one and draw a single line through that one. Because I really want you to know that BB is brain, MB is heart, and MM is skeletal muscle. So if your total CPK is elevated, do we know whether it's brain damage, heart damage, or muscle damage? No. So we can run the isoenzymes and determine which one's elevated. So in the case of BB, why would it be elevated? So you could have trauma, right? Car accident, trauma to the head. How about a brain tumor? Right? CKMB again, heart. MM can be elevated in the case of, so let's say you ran a marathon. Muscles went through a lot, right? Be elevated. Or you're up, roofing your grandma's roof because, she just loved you to death and wants you to put her new roof on her house. So if I'm working out in the yard and I start having chest pain and I go to the ER and my CPK is elevated or my CK is elevated, to tell whether or not it's because I've been working out in the yard or if it's because I'm having a heart attack, you would run your isoenzymes. Make sense? All right. Hemolysis can cause an elevation. Again, elevated in strenuous exercise, surgery, and intramuscular drug injections. intramuscular, those are the IM, the deep muscle injections. Gamma GT. Gamma GT is basically an alcoholism marker. Source of your liver, kidney, and brain. But again, elevated in certain drugs, and again, it's an alcoholism marker. So if my GT were elevated, and my alk phos was increased, I would say I'm having problems with my liver. But if my GGT is normal, and my alk phos is increased, because remember your alk phos can either be bone or liver, correct? If my alk phos is increased, then I know it's bone. So again, by running a couple enzymes, it might be having more than one tissue. By running one separate, together, gives us an idea of what's going on. We don't get orders for GGTs all that often. Glucose 6-phosphate dehydrogenase. Again, you probably talked about. I'm good. How are you? Yeah, good seeing you too. She looks familiar. So if you're ever in Walmart, you're like, hi, and I just give that hi. That's why I remember who you are. I'll ask Jess. Okay. Let's see. So what do I want you to know about G6PD? Okay, so we're talking about hemolysis. Does hemolysis affect the testing? Okay. To do a G6PD, because it is in your red blood cells, you have to make a red blood cell homolysate, which basically means you're going to take your red blood cells and rupture them on purpose. So will hemolysis affect your result? Exactly. Not falsely, right? Exactly. Hemolysis does not affect the G6PD, because that's what you're doing. You're doing it on purpose. Lactic dehydrogenase, LDH, okay? So we know we talked about do electrophoresis on your LDs, okay? So you have LD1, LD2, LD3, 4, and 5, okay? That is a normal pattern for your LD. Okay, 1, 2, 3, 4, and 5. Okay, divided into its isoenzymes, LD1. If you're having a heart attack and we apheresis your blood, your pattern looks like you get what's called an LD flip. 1 now becomes taller than 2. So it's kind of looks more like a foot.
You say that's when the blood is lit.
When you are having a heart attack, your LD1 fraction will become higher than your LD2. LD3 is increased. It is pulmonary. And LD5 could be liver or muscle. So you would have a higher peak in muscle. Okay.
How quickly does the LD1 lower? So I mean, do you have to take that test when you're having the heart attack, or after the heart attack you can take?
That'll be in cardiac markers, and we'll talk about that as far as when, because there is serial testing, so we'll talk about that in cardiac markers. As far as when to test. Okay, RBC hemolysis will increase the value, and we're talking greatly increase the value. Okay, Again, because LD is high in red blood cells. So if you rupture the red blood cells, you're gonna have an increase in your LDH. So diagnosis summary, so kind of just putting them all together. If we think you're having a heart attack, you'd have an elevated CK, AST, and LDH. On your isoenzyme patterns, your CKMB is going to increase, and your LD1 would be increased over your LD2. Liver disorders, AST, ALT, LD, GGT, remember with the alcoholism, and your alphos. Skeletal muscle disorders, the elevated CK, AST, and LD. Bone, alphos. Malignancies, nowadays we just do tumor markers. And acute pancreatitis, Amy and lipase, skip down the road. Okay. Now, we'll put you back to the quick little thing for you to help remember.
What do you want us to take in higher voltage?
That's in your next lecture. So what do we have? Let's go over our hemolysis. Alphos increased, decreased.
Increase.
Acid phos, I'm sorry, in acid phos,
Increase.
increase. Alkaline phos, GGT,
Not applicable.
ALT, AST,
Increase.
LD,
Increase.
CK,
Increase.
amylase, lipase,
Decrease.
decrease. Lipase is decrease. G6PD, cholinesterase, myoglobin.
No idea.
Oh, yeah, we have that. Okay, so, yeah. Heart attacks are big business. Because if you're having a heart attack and you go to the emergency room and they can't prove that you're having a heart attack and they send you home and you die, Brown and Croupen's going to be knocking on the doctor's door going, how can we kill the patient, right? So we have to be very careful that we don't send people home that are really having a heart attack. And there's that fine line between what the insurance will pay. So if we think you're even remotely having a heart attack, we can prove at anything, okay, we're going to keep you for 23 hours and 59 minutes. Because we know the insurance will pay for at least 23 hours and 59 minutes. Okay, so cardiac markers are big business. We have to find out then within that 23 hours and 59 minutes if you're truly having a heart attack. So if we can prove that you did, then we can keep you over the 23 hours and 59 minutes and insurance will pay. If we cannot prove that you did, we're going to send you home. Okay? Big business. It's big business. So the ideal cardiac marker, I'm looking at my notes. The ideal cardiac marker, you want it to rise quickly, right? Because you want to get it within that 23 hours and 59 minutes. You want it to go away after we fixed it, right? So we can tell whether or not you're having another one. Right? We need it to be pretty sensitive for very minor heart problems, right? Again, we need to have it sensitive so we don't send you home so that you have a heart attack, finish having your heart attack at home and you die. All right? We need to be able to use it to monitor your progress in your therapy. Are you getting any better? Right? And again, we want it to be negative in patients who are not having a heart attack. Right? Because we want to be able to send you home if you're not having a heart attack. Determining factor size, where it's coming from, solubility, clearance, all that good stuff. That's just some things that help determine what makes a good cardiac marker. So molecular molecules are released into the bloodstream following tissue injury and a heart attack. So your heart has damage and it releases into the blood. And that's what we do. Does this person like people? Okay, so here's your diagnostic window. And this is kind of a brief summary of everything we're going to go through in a minute. So you're going to hear all this lot. So myoglobin is released in 1 to 4 hours. So is that in my 23 hours and 59-minute window? Okay. And then it's going to return to normal within 18 to 24 hours. So why is that important if my patient said, well, yesterday I was mowing the lawn and I thought I was having some chest pain, but waited until Monday morning to go to the doctor? Because his myoglobin could be normal, right? So again, we don't know. So your CPK, CKMB, remember, is the isoenzyme fraction of the CK, rises in 4 to 6 hours, peaks at 12 to 24, returns to normal in 2 to 3. So if I'm peaking at 12 to 24, they're going to admit you, correct? So then we can watch it come back to normal, 2 to 3, and say you're over your heart attack. Okay. Troponin T, again, when it rises, that one will go from 7 to 10 days. Okay, so that's that person whose doctor's on vacation and refuses to go to the emergency room, comes 2 weeks later to the doctor. Okay, maybe he's still got some residual. Troponin I, again, normal within 6 days, so a little bit less. And we'll talk about each one of those. So again, the traditional tests way back when were your CPK, your AST, your LDH, and again with your LDH blip. Okay. Newer tests have come and kind of not necessarily replaced them, but are better markers for cardiac. Are your myoglobins, your troponins, and your CPKs, and isoforms. So, with the old technology, your CPK is going to elevate first, then your AST, and then your ALT is going to peak, then stay idle. C, A, as far as how they're going to elevate and stay elevated longer with the old ones. Okay, creatinine kinase, we've already talked a little bit about it. Your CPK normally should be less than 100. If your CKMB is less than 6% of your total CPK, you're normal. Okay. Your CPK will be increased 4 to 6 hours after the onset of chest pain, peak, and then return to normal. Again, that's just kind of the culmination of the things that we had. CKMB. Have your BB fraction, which was brain, MB is your heart, MM was your cardiac muscle, or I'm sorry, cardiac muscle, skeletal muscle. Okay. We can do a CKMB index. Take your CKMB divided by the full CPK times 100. If an index is greater than 3, is indicative of myocardial infarction. And in all honesty, nowadays the machines do that all by themselves, and they report out the index all by themselves. We don't have to do that calculation. Cardiac troponins. All the other ones we've been talking about were enzymes. CPK is an enzyme, LDH is an enzyme, AST is an enzyme. The troponins are proteins. So on your test, you're reading a test question and it tells you which protein cardiac marker elevates early, or which enzyme cardiac, so read the questions carefully. Am I talking about a protein or am I talking about an enzyme? Okay. So there are three forms, troponin T, I, and C. C we do not use as a cardiac marker. I don't even know that C has any commercial use. The first one to come out was a troponin T. Okay. And then I think Roche had it first. And then, so we all use troponin T's. And then Roche got, and then once everybody else kind of got on board with the T's, Roche said, oh no, we're not going to be outdone. We're going to come up with the troponin I, which is even more sensitive. But again, you would want to do serial blood draws in certain hours again to get it to that 24, that magical 24 hours. Each one of them separated. Okay, troponin I is more specific and sensitive for an MI. That's the newest one. Again, Roche came out with it first. I'm not even sure if anybody else has it, do they? Maybe by now. Not found in patients with other injuries, okay? It is not affected by renal failure or skeletal muscle disease. Very sensitive for cardiac. There's when it rises in cause. Okay, troponin I ultra is even more sensitive. I think that's the new generation. Is troponin I ultra. So troponin I is more sensitive for cardiac. Troponin T.
Is troponin 1 affected by hemolysis?
It is. It decreases it. And so do we want to decrease value on our troponin? Because we don't want it to be negative when the person will have a heart attack. So yes, this is very important. This was one of the ones that we had that little picture of what was acceptable for hemolysis. When we first came out with them, we actually had to hold the tube up and see what was acceptable. Because if it was hemolyzed and it decreased the value, then we were sending people home that were having heart attacks.
I seen Google yesterday.
The lipemic ones don't bother me. It's the icteric ones that bother me. You know, the ones that are that kind of really nasty orange color. Those are the ones that bother me. Okay. Troponin T, again, we're out before troponin I's. But the problem we had were false positives with end-stage renal disease. So people with kidney disease. We had a gentleman that, homeless gentleman, who, when it would get cold or when he would get hungry, he would come to the emergency room and say he was having chest pain. And because his kidneys were shot, we run a troponin T, and of course it would be elevated. So of course we can't send you home, right? And so we would bring him to the hospital, and we would take off his clothes, and we would wash them for him, and we would feed him, and all that good stuff. And then come to find out, you know, it was just elevated because of his, you know, kidney disease instead of having a heart attack. We finally got smart, and then when the troponin I's came out, we're like, who, because we knew, you know, who he was, what his game was. But that's a true story. I am not lying. That's a true story. So again, not as specific or as sensitive as the troponin I, but we'll stay elevated longer. So troponin T's were out there, and then troponin I's kind of wiggled their way in. For the bulk of them, we ran troponin T's, and then only did I's for the ones that were wishy-washy. Okay. Now we don't even run troponin T's. We only run troponin I's. Again, the technology's gotten a little better. The prices come down, and so we just do troponin I's now. Reference values for troponin T and I, again, less than 0.6, no myocardial damage. 0.6 to 1.5 is borderline, so we're probably going to keep you. And greater than 1.5 means you have. The higher the troponin I, is really significant for irreversible damage. So even you can have a high enzyme, it means you had a heart attack, but usually when your troponins are really elevated, actually got to that point where it was necrosis of the heart tissue, so you had almost irreversible damage to the heart, but it gets really high. It was, my husband thought he was having a heart attack. He had quit his job that he'd been at for 10 years, and he was going to another job, and it was that week in between, and he comes out of his office and says, I don't feel very good. And I'm like, okay. And I said, just sit down, whatever. He was white as a sheet, I said, just relax. And so he gets up a few minutes later and goes, I'm really not feeling good. And I said, okay, fine. Let's go to the emergency room. Walk in the emergency room, you got this old overweight guy, and tell him that he's having chest pain. Of course, everybody's went to flurry of activity. And I was actually in scrubs, and I don't remember why, because I was here at the hospital. I don't remember why. And so, of course, they knew who I was. And so they did all kinds of stuff. And they actually ended up keeping him overnight. But while he was in the emergency room, we did, at one point, we did point of care testing for cardiac. So they would draw blood in a purple top tube, and they would do the little cartridges, kind of like your pregnancy kits, right? And then just point of care. And so the machine was in the room that they had him in, and she put the specimen on there. And then after a few minutes or whatever, I heard it print onto the little printer what the results were. There was nobody in the room, so I just got up and looked at the results. I said, you are not having a heart attack. So, ended up just being anxiety, which, of course, we quit moving one job to the other. So we joke about it. So I'm sure that was a HIPAA violation. I probably shouldn't have looked. I won't tell anybody. If you tell anybody, I told anybody, I'll deny it to my dying day. So again with this one, false decrease with hemolysis. And so do we want a false decrease? No. We want to make sure that it's where it needs to be. Troponin C, again, that's not one that we tend to use, but a little bit about it. Calcium binding. Okay, myoglobin. Myoglobin, again, is a protein, not an enzyme, right? It is a protein. A heme protein found in skeletal and cardiac muscle. Myoglobin can, when it is increased, can say that we have muscle damage. Skeletal muscle or cardiac muscle, okay? So if there's muscle damage, we will see an increase in your urine myoglobin. We can use a dipstick to test your urine to see whether or not you have blood in your urine, correct? Okay. You can use a dipstick to find myoglobin. You probably talked about this, right? The myoglobin will actually give you a positive on your dipstick. You got that far in your analysis? No. But you can. All right. But again, because you can have blood in your urine for other things, do we really know if you're having a heart attack just because you have blood in your urine? No. But we can do that, right? In the old days, that was the first thing we did, because we did a dipstick on the urine to find out whether or not your blood was positive, okay? So it's really non-specific, and you must rule out non-cardiac causes, but it is very sensitive. It is a good negative predictor. Which means if you don't have myoglobin in your urine, you did not have a heart attack. Having blood in your urine does not necessarily mean you had a heart attack, but by not having it means you didn't. Does that make sense? It's a good negative predictor, all right? It is one of the first markers that's released. So again, if you have no increase in a myoglobin after 3 hours, you had no MI. So is that within our 23 hours? Exactly. So if we hold you for 23 hours and you never get any myoglobin in your urine, we can say, okay, you didn't have a heart attack. We can send you home. So it's a good negative predictor.
And hemolysis would decrease the results of this too, or it's not effective because it's.
Well, because we're not testing blood, we're testing your urine for myoglobin.
The myoglobin is only urine, it's not your blood.
You can have hemolysis in your urine though.
I'm sorry?
You can have hemolysis in your urine though.
Well, and that would increase it, yes. But again, that's not what we're looking for. I mean, yes, we are, but you're making it too complicated. Yes, you would have an increase if you had hemolysis of red blood cells, but it's not going to be increased due to an increase of myoglobin. You're gonna do a test. Let's see, negative myoglobin, you don't have an MI. High myoglobin, you have an MI. Again, peaks quickly, goes away quickly. level is proportional to the degree of infarct, and again, false negative, clear. So, again, if you said you were having chest pain yesterday, you can go to your doctor until Monday, you could be negative. So how to test whether or not it is myoglobin or hemoglobin? You can do an ammonium sulfate precipitation. Did you type out this in your urine? I don't know if she did or not. I know she does at one point. It does take about 15 mils of urine. You can do the precipitation test. Find out whether or not it's myoglobin versus hemoglobin. It turns yellow. I'm an orange yellow. BNP is a specific marker, okay? Increased in coronary heart disease, congestive heart failure, I'm sorry, congestive heart failure. Release from heart muscle, left ventricle. So congestive heart failure, good marker for that one. Increase the urine output of the kidneys associated with heart condition. Yeah. Yep. And
Do you want to see these now if you're done with them? Or
you're all done?
wait until
Yes.
I looked through it. I even corrected the things they told me. This one, it's more difficult just simply because for me, I've been looking at these enzymes for 30 years. It pops in my head. I know what's a liver, I know what's a heart, I know what's a this and what's a that. For you, it's just memorization as far as which ones are which tissue. And that's the things that I'm going to ask you right now about, what tissue or disease. Yes, ma'am.
Is AFib a cardiac marker?
I'm sorry?
AFib?
AFib is a heart condition.
Is it not a cardiac marker?
It's a condition. It's not a cardiac marker. Hernia, not a Just me this time.